Welcome and thanks for joining us. My guests today are Dr. Catherine Bigger. She's the Principal Technical Advisor for Virology at LMI, and Dr. Brandon Greenberg, a Fellow for Resilience at LMI. I'm your moderator, Tom Temin. This discussion is Investing in Public Health, Lessons Learned from COVID-19, sponsored by LMI, here on Federal News Network. And good to have you both with us today. And one thing we know for sure now as we enter the middle of the summer here, we have actually been through a pandemic, something I think a lot of us have never really experienced personally in our lifetimes, maybe a century ago. So one thing I think that we need to discuss, and I know this is an area of expertise for you guys, is the mitigation and response efforts of the government were shown to be great in some cases, not so great in some other cases, definitely ready for revision. So let's begin with how we think about the next time this happens, and we're pretty sure there will be a next time. Brandon?
Yeah, I think COVID-19 has really shed some light on the complexity of mitigating risk and trying to respond to these crises and these disasters. The pandemic, in terms of its unprecedented components, was basically national and even global. And so when we look at that perspective and that level of analysis, it's really important to kind of look at the system behaviors and understanding that it's not just a simple, straightforward approach to risk management or a simple, straightforward one-off approach to how we respond. It really is, it's a coordinated collective effort that needs to occur. And how do we foster that through the federal government? How do they enact policy and how do they enact change to enable us to be ready for the next pandemic or the next disaster that's going to occur, especially at this scale?
And Dr. Bigger, the interesting thing about this particular pandemic was that we now know what happens when you have a viral or medicinal type of event overlaying other activities. You look at the search and rescue efforts, say for the collapsed condo in Florida, or a weather response, you still have the overlay of the pandemic aspect of it. And so that must affect how we respond and think about response in the future also.
Well, that's true. I believe we had 2 hurricanes in the Gulf during the pandemic, and there were people having to take refuge in general locations for the public. There were fires in California that required teams of firefighters. It required evacuation of communities, teams of firefighters that had to co-locate and do shifts. And so during that period of time, there were, and this is prior to the vaccine and prior to some of the therapeutics, so they did have to, there was a lot of risk there. If it's okay, I'd like to back up a little bit. So this is, we had a pandemic in 2009 from influenza, from a new H1N1. And so we typically have pandemics every, it's not set, but every 20 years. This has been every 10 years, 2009, 2019. But we will have a pandemic every 20, 30 years, 50 years certainly. And so a lot of times the government preparation has been for influenza because of the influenza pandemics that we've had over the last 100 years since 1918. But we have had regular pandemics in addition to this one. This is listed as currently the 11th worst pandemic out of about 20 that are historically important for human society.
Got it. It's not quite the Black Plague, but it's a lot worse in terms of how widespread it was than some of the earlier ones in recent years, which didn't affect the United States in the mass way quite as much as it did, I guess.
Not since 1918 have we had this level of death and this level of infection and obviously hospitalization.
All right, so how do we think then about readiness? Because as you point out, this does happen regularly. Now it's happened to us and could happen to the United States in a much more profound way. And I guess we are kind of the backstop for a lot of the world when even it doesn't come deeply into our own shores. So how do you define readiness now in this new post-COVID era?
So we have all these private sector, public sector entities across the federal government, state, locals, even international components. We're all trying to minimize risk to pandemics together. We all have different philosophies or approaches depending on the constituents or citizens that we serve. And so it's important that we can't go with this command and control model, but we have to go with an influence and behavioral influence model of how do we ensure that state and locals are as prepared as they need to be? How do we ensure that the federal government is playing the right role in readiness across the nation and also in collaboration with our international partners as well.
And besides that behavioral and kind of new way of thinking about it, there are also really some practical concerns. We learned, for example, of the interdependency of the medicinal delivery system, the medical system, and the supply chain system. And there was really serious issues there early on. And so that seems like something we need to think about, supply chains from a very practical standpoint.
That really hit us where it hurt. Insofar as acquiring everything from reagents to viral diagnostic kits, needles, tubing, plasticware, tubes that you would use in the laboratory, everything, and even laboratory animals. Some laboratory animals to this day are still hard to get, hard to purchase, and hard to use. So there are backlogs of testing and various drugs that are in, when you're doing the animal studies, typically every drug goes through a toxicology, pharmacology test. A lot of tests, non-clinical testing, is done prior to even getting to a phase 1 clinical trial for safety testing in humans. But a lot of those animals are backlogged, and those studies are backlogged. And so when Brandon talks about the supply chain management, that's where this country really, really was hit hard, aside from the human impacts.
Because stockpiling is not necessarily a great answer. You certainly can't stockpile laboratory animals, but even things that are non-living deteriorate, they get obsolete, the packaging goes bad and fails and so forth. So that's not really necessarily the answer either, is it?
Yeah, I mean, it's not a straightforward answer because, you know, a next pandemic or a next medical emergency may not manifest the same way as COVID-19. And when we look at the medical supply chain, the vast majority of it is private sector, and a lot of it is offshore. And when you look at the stockpiles, they have to go through rotations themselves because a lot of the equipment and materials, they have shelf lives or they need to be maintained. And so the trick is to find the economic balance between how much do we stockpile and maintain as a buffer stock or buffer readiness versus how much do we put investment in capabilities to produce rapidly if we need to? How do we put prioritization on perhaps raw materials that the federal government can distribute to atypical manufacturers in a situation where they can retool their facilities to support the supply chain demands of the disaster taking place?
Yes, because early on there was the perceived need, at least, for ventilators in mass quantities. And what we learned is that automobile manufacturers can pivot factories to take intellectual property from people that were already making ventilators, and then the car manufacturers could make ventilators. Turns out they weren't all needed. Most of them were not needed, but no one could have anticipated that. But nevertheless, there's a lesson there that seems to be worth preserving with respect to that ability to pivot and be agile.
There is, and that includes understanding intellectual property rights and being able to, in an emergency situation, be able to synthesize or acquire materials, including virus stocks, from different locations throughout the world and throughout the country, either for local assessments, local analysis, such as looking at variants, to transferring those to places like the CDC so that they can continue that analysis. Viral stock availability was even originally not that widely spread, so that inhibits even, starting at the point A. So that plus plastics, for example, to make syringes. If we stockpile the raw materials to do that, we can then move into a realm such as 3D printing, which that was done to some extent at the DoD level, where we 3D printed swabs. So we ran out of swabs to do diagnostic tests. But we were experimenting, several folks on my team were experimenting with looking at different 3D printing mechanisms to make swabs. So insofar as maturing our process and moving into the next phase of these types of responses, those would be areas to grow.
And if you look at this whole supply area that we've been talking about, you really have to look at that in the context of an end-to-end life cycle, which gets to the distribution of resulting supplies or in our case, recently, the resulting vaccines. And so then you have the issues of distribution and distribution so as to be equitable for all socioeconomic factors. And I think there's some lessons learned there too, correct?
Yeah, I mean, health equity and equity, disaster equity in general is a hugely important topic. It's not just about can we provide the health care, but understanding what populations may be impacted more than others, and how can we close the gap between the services that they may receive versus other populations. And it's incumbent upon, I think, the nation to really close the gap in equity issues. And I think supply chains are kind of one of those examples of where can you best distribute these supplies, and where can you best ensure that everybody has equitable access to the vaccines, and the communities have access to the medical supplies that they need in order to provide good care.
And Catherine is someone who has operated in the medical federal system, with some real considerable experience there. Where does the responsibility lie? Where does the thinking best be located for this end-to-end view to make sure that there are equitable distributions and outcomes? I mean, is it CDC? Is it some other part of Health and Human Services? I mean, how do we think about this in a governmental system way?
Well, with the pandemic response for COVID and with the pandemic response for H1N1 in 2009, it becomes you'll hear this phrase, an all of government response. And your typical government agencies that have their siloed concepts, those silos will be lowered, and we see a lot of interaction, interagency interaction across government among NIAID, NIH, National Institutes of Allergy and Infectious Diseases, we call it NIAID, obviously, and then BARDA, Biomedical Advanced Development Research Authority. A lot of different government agencies. CDC, of course, is the premier infectious disease agency, pretty much for this country, and is relied upon throughout the world as well. So those silos tend to come down, and we see a lot of teams formed that are interagency associated. We have a lot of meetings. But while the response in and of itself was robust for COVID, and it's still ongoing, I don't want to say COVID is over, we're still in a pandemic, but while the response is robust, we tend to, in this country, have a knee-jerk reaction. We have responsive reactions instead of preparatory reactions. We do have a lot of preparation for influenza pandemics. We have an entire world network of sequencing, certainly a North American focus and an international focus, North and Southern hemispheres, a national focus. We have a very robust network for that. We tend to focus more on influenza, and it does get the lion's share of the funding. Obviously, this is a different type of virus with coronaviruses. Among the intellectuals, the academics of the world, we understand that there are measles-type viruses, paramyxoviruses, coronaviruses that are out there circulating, but the surveillance for those is less. So that's one area of improvement. But perhaps more preparation. I don't want to say that we don't prepare, because we have a lot of documentation, we have a lot of practicing in terms of intergovernment agency and what to do. However, I would say that we tend to be more reactive than we tend to be proactive, and that's somehow also tied into our election process as well. Different funding, different administrations fund these programs at different levels, so you'll see a cycling effect, and that has a dampening effect on preparation on the whole. Instead of staying at an even level, it tends to go up and down.
And if I were to add to that, be in a more proactive posture, we really need to be learning about the next disaster and not just focused on learning about the disaster that we just went through. It's really important that we kind of look at the realm of possibility and understand the complexities associated with the risk management, with the response and recovery efforts, and what that will truly entail perhaps in another situation, or if a pandemic combines with a series of wildfires that occur more and more often and are on the rise as well.
All right, we're going to continue on that thread, but at this point we have to take a break. When we come back, I want to get into more of the organizing principles and the look ahead here for the future.